Bupivacaine, also known by the names of Marcaine and Sensorcaine, is an amide local anesthetic agent. Molecularly, local anesthetics consist of a lipophilic aromatic ring and a hydrophilic tertiary or quaternary amine connected by a hydrocarbon chain. An ester or amide bond facilitates linkage between the lipophilic portion and the hydrocarbon chain and acts as a differentiating factor between local anesthetic classifications. As an amide local anesthetic, bupivacaine has an amide bond. Here you can see the aromatic ring on the right and the piperidine nitrogen with the butyl group on the left. The butyl group serves to increase the lipid solubility and the potency of bupivacaine. Bupivacaine has a relatively slow onset of action compared to other local anesthetics due to its pKa of 8.2. The further a pKa value is from physiologic pH, 7.4, the greater the amount of time will be required for ionization and crossing the nerve cell membrane. Enhanced drug protein binding results in elevated concentrations of bupivacaine in tissues near the sodium channel receptors, meaning that the drug remains in the channel and surrounding areas for a longer time, producing a prolonged conduction blockade. This is noted by bupivacaine's very long duration of action, up to 10 hours or more. Metabolism of bupivacaine occurs via hepatic microsomal cytochrome P450 enzymes through a complex process that might play into its long duration of action. New developments and FDA approvals have recently transpired regarding liposomal bupivacaine through liposomal encapsulation of bupivacaine molecules. These formulations provide slow, sustained release of bupivacaine following a single injection and not only produce prolonged analgesia, but have an opioid-sparing effect. As more conclusive evidence on this surfaces, its clinical use is likely to expand. Bupivacaine exerts its action through effects at the sodium channels and nerve cell membranes. Bupivacaine is classified as a weak base that exhibits acidic behavior in solution. Following injection into a physiologic environment that's a bit more basic, it loses its charge and has a greater ability to cross the lipid bilayer of nerve cell membranes. Once inside the neuron, bupivacaine picks up a proton due to changes in the pH of the intracellular environment. The bupivacaine molecules must regain this charge to selectively bind to the sodium channels intracellularly, where they create an inactive closed state of the voltage-gated sodium channel. This closure inhibits the passage of sodium ions and thus the conduction of nerve impulses through propagated action potentials. So, as you can see here, the bupivacaine molecules permeate through the nerve cell membrane and pick up a proton in order to maintain equilibration in the slightly more acidic intracellular environment. Then the bupivacaine molecules bind to the intracellular portion of the sodium channel and inactivate it. Decreased sodium channel permeability to sodium ions diminishes the depolarization rate of the neuron, which results in failure of the neuron to reach threshold potential. This prevents action potential propagation and causes blockade of impulse conduction. Bupivacaine is indicated in the treatment of various acute and chronic pain conditions through wound and tissue infiltration, peripheral nerve blockade, and neuraxial anesthesia and analgesia. Bupivacaine is appropriate for procedural or surgical anesthesia and can also aid in reducing perioperative stress. For use in local wound and tissue infiltration, a 0.25% solution is injected into the extravascular space to produce immediate, short-term analgesia. The maximum recommended dose is 175 milligrams in the absence of epinephrine or 225 milligrams in the presence of epinephrine. To achieve peripheral nerve blockade, a 0.25 to 0.5% solution can be injected in the vicinity of a peripheral nerve where bupivacaine will diffuse through the surfaces of the nerve. Again, the recommended maximum dose is 175 milligrams without epinephrine or 225 milligrams if epinephrine is used. Epidural and spinal anesthesia and analgesia can be achieved with a 0.5 to 0.75% solution. However, max doses here must be carefully considered. For epidural, max bupivacaine dosing is 175 milligrams without epinephrine or 225 with epi, while spinal injections require far less drug, with max doses being 20 milligrams. Bupivacaine, as well as other local anesthetics, can block action potentials in various nerve fibers. Relevant factors to local anesthetic blockade include nerve fiber diameter, myelination status, and position of the nerve fiber within a bundle. Small diameter nerve fibers are most sensitive to local anesthetic and will experience inhibited conduction at a greater speed than large diameter nerve fibers. Unmyelinated fibers are blocked more readily than those with myelin sheaths, and fibers located on the perimeter of nerve bundles will be susceptible to the effects of local anesthetics sooner than those that are in the core. So, this supports the idea that pain and temperature are most rapidly blocked by local anesthetics, while deep pressure and motor function are blocked much later. Recovery from local anesthetic will occur in the reverse order of the onset. It is often difficult to distinguish adverse effects of bupivacaine from the desired physiologic effects of the nerve block, but side effects include peripheral vasodilation and resultant hypotension, bradycardia, dizziness, nausea, vomiting, and urinary retention. Contrary to the administration of ester local anesthetics, immune-mediated reactions are only of minimal concern with bupivacaine due to its amide structure and lack of allergenic nature of the compound itself and its metabolites. The most severe adverse effects of bupivacaine are related to systemic administration or absorption and the resultant toxicity that follows. The risk for inadvertent systemic absorption and toxicity likely stems from the prolonged blockade of sodium channels and slowed metabolism. Early signs of local anesthetic systemic toxicity typically include central nervous system symptoms such as lip and tongue numbness or tingling, metallic taste, and ringing in the ears. However, with further progression of toxicity, seizures, severe hypotension and dysrhythmias, and even cardiac arrest have been documented. Treatment of this toxicity includes immediate discontinuation of the local anesthetic, resuscitation, supportive therapies, and 20% lipid emulsion therapy. Lipid emulsion therapy acts as a lipid sink and aids in the removal of bupivacaine molecules from the voltage-gated sodium channels. Guidelines are ever-changing, but currently include a 1.5 milliliter per kilogram bolus, followed by a continuous infusion of 0.25 milliliters per kilogram per minute for 20 to 60 minutes or until hemodynamic stability is restored. Additional boluses and dose increases can be administered as needed. Recommendations to evade local anesthetic systemic toxicity include slow and incremental injection following aspiration. This is to ensure that you are not in the vascular space. We also need to ensure that we're always using the minimum effective concentration necessary to produce the desired blockade. Caution should always accompany the administration of bupivacaine. However, special consideration should be taken in patients with cardiac instability, severe hepatic dysfunction, pregnancy, and previously documented allergy. As I mentioned a bit earlier, amide local anesthetic allergy is unlikely, but it is still possible, so bupivacaine should be avoided in these patients. Cardiac instability and treatment with beta-adrenergic blockade, digitalis preparations, and calcium channel blockers may increase susceptibility for cardiotoxicity and dysrhythmias. It has been documented that with plasma bupivacaine concentrations as low as 2 to 3 micrograms per milliliter have caused severe dysrhythmias as compared to the expected 8 to 10 micrograms per milliliter threshold. Severe hepatic dysfunction can prolong the action of bupivacaine as hepatic enzymes are the primary mechanism of metabolism. During pregnancy, a slight metabolic alkalosis ensues. This causes the pregnant patient to have a greater sensitivity to local anesthetics. It is also recommended that the 0.75% bupivacaine solution be avoided in pregnancy due to case reports of difficulty resuscitating following cardiac arrests. Here is a list of the references used throughout this presentation, as well as helpful reading regarding bupivacaine's use in anesthesia.